Hello and welcome to the AHF podcast. I'm your host, Joe Schwab. Today's episode is the second in our series of 6 surgeon roundtables recorded in partnership with Smith & Nephew. Conversations that bring together surgeons who do this work every day, peer-to-peer, with one goal: practical, reproducible techniques you can actually take back to your operating room. Last time, we took on the complex primary hip. Today, we turn to the complication every hip surgeon respects: instability. What does the data actually say about dislocation after anterior approach total hips? And how much of that risk can we actually modify? How should the hip-spine relationship change where your cup goes? What are the non-negotiable stability checks before you close? And when the risk is high, how do you escalate? Offset, length, dual mobility, constraint, without letting the most constrained option become your default? Well, 3 guests join me for this conversation. Dr. Jeff Berry, who grounds us in the literature on what we know and what we only think we know about dislocation in anterior approach hips. Dr. Blair Ashley, who makes the case that instability prevention starts in the clinic long before anyone picks up a scalpel. And Dr. Chance Gray, who sees what failure looks like in the revision setting and plans every primary by working backward from it. By the end, they'll lay out a practical end-to-end algorithm for preventing instability, from the first clinic visit to the final construct. And just like last time, it gets concrete fast. So let's join the conversation. Jeff, we read that some of your research interests include perioperative management and risk assessment, specifically managing complications around total joint replacement. So when we talk about instability in anterior approach hips, what's one misconception maybe that you still hear that the data doesn't really support?
Yeah, that's a good question. I think there's probably two misconceptions that I can kind of think of, and the first would be that I think there's a misconception that now we have this DA approach that instability has been solved in the arthroplasty community, and I think the data would strongly suggest that is not the case, at least in the general population. If you look at the big database studies, the rates of instability in primary hips is still probably about 2% in the first 2 years. So I think that misconception that now we're doing DA, instability is fixed, I think that's probably not true. But then I think the flip side of that is the misconception that we're never going to, completely solve it, or it's not solvable. And I think with DA hips, we can also, start to see some of these centers that have been doing it for a decade are starting to show outcomes where the rates are exceedingly low when done correctly with the right implants, with the right positioning, right soft tissue handling. So I think it is something that we can get to a point where it's, like polyware, a thing of the past. But to say that we're there now, I think would be false.
Blair, you're known for spending time with patients in the pre-op space and taking maybe a bit more of a conservative approach. From your perspective, where does instability prevention really start? Is it long before you get to the OR?
Yeah, absolutely. I think that patient counseling is such an important part of, managing expectations and making sure that you're actually going to give patients an outcome that they're happy with. So I like to certainly understand what patients' goals are after surgery. Obviously, when deciding someone's a candidate for surgery, that's relatively objective. That comes down to, are they radiographically a candidate? Are they in enough, pain, and are they functionally limited enough to be a good candidate for a hip replacement? But then it's also understanding, like, what is your goal? What are you trying to get back to? Right? Are you
Mm.
just trying to walk and do your activities of daily living, maybe some low impact cycling or water aerobics, things like that? Or are you trying to get back to skiing or intensive yoga or Pilates and things like that? And so in those situations, kind of counseling patients in terms of what your expectations are and what their potential risk could be is very important. So, there are certain complications that I like to really emphasize with patients like myself, not from my PA, not from just them reading the consent form, like coming from my own mouth and saying, like, look, this is something we need to be wary of. And certainly with hip replacements, dislocation is one of those risks that I really take time to discuss with patients in terms of the fact that this is not just you know, your first 6 weeks of surgery, we worry about this and then you're out of the woods. This is a lifetime kind of almost responsibility that you're taking on. And so discussing with patients if they want to get back to some of these higher risk or higher impact activities, that they are then assuming the potential that a dislocation could, occur to them, whether it be 3 months after surgery or 3 years after surgery, if they're not kind of being cognizant and cautious of that.
Mm. Chance, you've treated everything from primary total hips to complex failed arthroplasty. When you see instability after specifically anterior approach total hip, what's your maybe instinctive first question? Was this a planning issue, an execution issue, or patient factors?
Yeah, that's a great question, Joe. My instinct at this point is still, especially with anterior hips, I think my gut is always to look first at the cup. Um, my own personal experience has just been that in anterior approach hip replacement, especially instability, is almost always cup driven. So that's usually the first place I look. And I think we also you raised a great point about patient factors. These cases aren't just an X-ray you're looking at. You're seeing a person, and so sometimes you do get a sense when you meet a patient that, oh, this may be driven by a neuromuscular issue. This may be driven by as Blair was talking about, certain activities that they try and do that may not be appropriate after hip replacement. Is it some activity related issue? A lot of times, I feel like that can still be solved for most people, and so I usually look first at the cup. But then if the cup position looks good and looks normal, then we start going down this whole pathway of beginning to think about spinal pelvic issues or stem-sided issues. But in my personal experience, I think cup-driven problems are usually the root. I don't know if Dr. Ashley or Dr. Barry agree, but that's been my experience.
Yeah,
Well,
I mean, if
Jeff,
I
let's.
can kind of follow up. Oh, sorry, I didn't mean to cut you off, Joe. But I was gonna say I agree with Chance. I kind of those are my first things, and then I guess my other consideration is like is an offset problem part of this too, and I think you generally have like a good idea of that either preoperatively with your templating or postoperatively, but or sorry, like intraoperatively as you're trialing. But I will say that sometimes when I'm in the operating room and I'm not happy with my stability and my leg lengths are okay, the next thing I'm thinking about is that did I adequately restore offset? And I've been
Mm,
known to waste the occasional liner and put in a lateralized liner. And that helps me to address that issue. But I think cup is first and foremost the typical culprit. And then I'm also kind of thinking about offset if there's not some other good biomechanical explanation from like a spinal pelvic relationship or something along those lines.
mhm. So, Jeff, based on kind of current literature talking about dislocation patterns in anterior approach, and using your clinical experience, what do we know about dislocation patterns in anterior approach hips and maybe how it differs from other approaches? We heard some opinions from Chance and Blair. What do you think?
Well, I think that the dislocation pattern in general, I think in 2026, you can kind of say most literature, most people would agree, DA dislocation rates are going to be lower than posterior hips. If you look at all the papers that are put out, it's either going to show the same dislocation rate in maybe cherry pick studies or a better dislocation rate than posterior. And I think you just need to ask our trainees. I work at a training program. If you ask the residents how many DA hips they've reduced, it's going to be pretty much zero versus posterior hips. They've all kind of done a couple. Um, I'm not going to cover lateral hips so much because I think that should be outlawed. I don't think that's an appropriate surgery in 2026 in the US. I think, yes, you may be the most stable possible, but you've sacrificed probably the most important muscle on the hip. So that's not allowed, at least in my practice.
Mm,
The other thing about DA dislocations is that when they do happen, it's a little bit more of a mixed bag than posterior hips. Posterior hips almost always go out the back, right? They're going right back where they came from. DA hips is actually a mix. Like some will come out the front, but some will actually come out the back. So I've been referred, patients that have anterior instability, quote unquote, because they had a DA approach. And it's really actually positions that are coming out the back. So I think that leads to more of this point of the component position is a big deal, but also from a DA approach, it's soft tissue handling at the time of surgery that I think makes a big impact. And um, patients go out the back because we are sedentary, flexed hip position creatures, and that's just a more natural position to go out as flexed as opposed to this kind of extended, externally rotated leg where it needs to go out the front. So I think that's one nuance is trying to figure out what direction are they going if they are a DA unstable person, that you don't have to really worry about from the back.
Hmm. Chance,
Uh,
we all
I
know.
sorry, I was
Yeah,
Can I just add one comment there to Jeff's response? I think another piece of that is you sort of have to know your patient population as well. So I completely agree with everything that Jeff just said. But I live in a funny part of the world where we're close to the villages. So the villages is like this adult Disney World where everybody starts drinking at 2 p.m. in the afternoon every day, Monday through Sunday, and they spend an incredible amount of time on bar stools. And so I have had I can count probably, of all my dislocations I've ever had, which is not a ton, but I've had a few. It's been an incredible number that have been anterior dislocators because they sit on bar stools, and so they end
mm,
up with this funny sort of hyperextended pelvis, with a leg that's still, externally rotated, and so, oddly enough, we don't see very many posterior dislocations of anterior hips here, although I know the data shows that, and so, that's just one of these funny positions I'm now a little more aggressive at checking because I worry about I worry about my patients in that fairly unusual position that most of us
So
don't
you do
spend a lot of time in.
like a Captain Morgan test, or what are you doing for that bar scope? Yeah.
Yeah, I mean, it's that, I have a bump under the pelvis. I do non-table anterior approach. So we have a bump under the pelvis, which kind of recreates that a little bit. And then that sort of hyperextension, external rotation position. But I take it a lot more seriously now than I did a few years ago, just as this weird group of people we see.
have you published on the barstool simulation approach? Is that
No, that's a great
You
idea though,
should.
actually. Yeah, I think that's my next research project. I love it.
Staying with you for a moment, I think we got a good idea of some of these, the pattern of dislocation in anterior approach hips from Jeff. When you're starting to look in revision settings, do those patterns change sort of meaningfully, or is a revision kind of regardless of where they came from initially?
Yeah, maybe let me get a little clarity on your question, Joe. So, are we talking about when you're worrying about dislocations after revision, anterior
Exactly.
approach surgery? Okay.
Exactly.
Yeah. So, I'll specify for myself my typical revision approach for patients who I'm addressing, whether it's instability or lysis or whatever the issue is. I typically only do cup-sided revisions from the front. So if I'm doing any femoral sided work, I'll typically still go posterior. Um, but yeah, I think the same concerns arise. If we're talking about doing an anterior based revision, whether cup or both, soft tissue handling becomes essential. You want to, you have to take away scar to appropriately visualize your components, but you do want to be a little careful about preserving as much soft tissue envelope around the hip as you can. And then, but I do basically the same. Sort of provocative testing with those patients. I want to range them in extreme positions after with trials in, and to my knowledge, I don't think that instability after revision anterior approach is a big issue. I know after posterior approach it can approach 10% in some series, but I have not seen the same with my own experience for anterior based revisions, and I'm not aware of it being as big an issue.
Yeah. And Blair, for you, knowing that anterior approach in a revision setting typically doesn't have the same instability issues that you see in posterior approach, how do you translate that information into a patient conversation without maybe
Mhm.
sort of over promising?
Yeah, for sure. I mean, I try to give people whole numbers. I find if you really get into the nuances of data that, you get kind of blank stares during the headlight look. So, um, I tell people, we're looking at about a 1 to 2% risk of dislocation in this particular scenario. And then, if I still get funny looks, I'm like, 2 out of 100 people, but just trying to explain that it happens. It's not zero. And I think as we've been talking about, um, during this time is that, sometimes there is this idea in the kind of popular public literature that like, oh, direct anterior hip so you don't dislocate. So some of that is just kind of re-educating people that that number is not zero. We're looking at single digit, I say single digit risk, but the risk is there. And then that's kind of like the baseline risk for everybody. And then again, going back to kind of patient specific factors, it's like, well, do you have a lumbar spinal fusion? Do you have SI joint fusion? Do you have a history of seizures, Parkinson's disease? Do you have a connective tissue disorder? Is there anything else about that individual that makes me more concerned? And then that's a conversation I have with them where I say, okay, well, maybe this 1 to 2% is for the general public, but for you, I'm more worried because X, Y, or Z problem. And so I think there's a little bit of that element too, is just kind of giving people a baseline and then talking about them specifically to kind of make it more real for them. And then to Chance's point, if you're going in a revision setting, explaining to that person, like, look, I need to do a little bit more work to get the visualization that I need in order to do the surgery appropriately. So, and even in a primary, I do a capsulectomy. I'm taking the capsule out entirely. And typically that reforms, in about 6 weeks or so. But again, kind of counseling patients that while this is a risk for your entire life, we're most concerned in those early, couple of months while those soft tissues are healing and reforming. But yeah, I think as concrete as you can be about numbers and specific concerns you have with that patient, I think that's really important. And then that's a time when I start to talk to patients about like, well, what would I do in the OR to help mitigate your risk? Am I going to
Hmm.
change my liner option? Am I going to make you a little bit long if I need to? And kind of tying in those elements of like what is my plan A, B, and C when I get in there, and I think that helps to make it a little bit more real for them.
So, staying with that sort of patient specific counseling, how do you how do you separate, Blair, a patient's sort of modifiable risk factors for instability specifically from those you simply kind of need to plan around?
Yeah, absolutely. I mean, I think going back to the bar stool, challenge, there are some kind of patient behavioral issues that you can talk to people about. If they do drink a lot, I mean, that's something to talk about. That's a well-established risk factor as patients with excessive alcohol consumption could be an increased risk for dislocation. Maybe patients that have a seizure disorder, making sure that they're well controlled on their medication. Some of these medical issues can be optimized and modified to some extent. There are patients who are fall risk for other reason. Maybe they have like orthostasis. Again, these are medical issues that can be optimized before surgery and kind of being cognizant of that and talking to patients about that. I also find that some of my patients, while the patients are not bothered by using a cane or a walker, their family members get very obsessive about like, well, I think they should be done with their walker by now. I think they should be off the cane by now. And living in the Northeast and operating over the winter, I'm like, please just keep the walker for an extra 2 weeks, right? It's icy, there's salt on the ground, just like manage that. So I consider those kind of modifiable things and talking to people about how to best protect themselves. But then obviously there are non-modifiable issues. So patients that already come in with a fused lumbar spine or, lumbopelvic spinal fusion, like that is what it is. You got to work with that. Or again, patients maybe with a neuromuscular disorder, it is what it is to an extent. And so that's just talking to the patient that, look, you're at an elevated risk, and this is what I'm going to do to manage it. Maybe I'm automatically using a MDM liner, for example. Like that's a situation where I'm automatically doing that. And I explain that to the patient even ahead of time so they understand that I'm doing something to try to be proactive.
Hmm. Jeff, which modifiable risk factors do you think are maybe the most under addressed?
Yeah, so I'm going to be a little bit contrarian maybe here. I don't really consider risk factors for instability to be modifiable. So you just heard a bunch of really, very well established risk factors that exist, but in my mind there's complications that are kind of maybe more patient driven and there's complications that are more surgeon driven. And to me, instability is, if there's an instability problem, that's a me problem, not a you problem. So I need to do a hip replacement in such a way that doesn't matter if you have a seizure like that. If you have epilepsy, you may have a seizure at some point, and it needs to be kind of bulletproof to that. So I don't really think of it so much as a like ahead of time optimizing as what am I going to do in surgery to change, or what am I going to modify maybe to make this as optimal of a construct possible. And so that's where, Blair mentioned kind of using or 3.0 or some dual mobility type construct. If there's something that's making me worried, um, I'm going to optimize my position of components. I'm going to be really careful with the soft tissues like I always do. I'm going to make sure I restore the leg length and offset. And then even if I feel stable, if I'm worried, if they have one of these risk factors, I'm gonna pop in a dual mobility without hesitation.
Hmm. Chance, do you think about non-modifiable risks as something that still deserve a strategy, or how do you look at that?
Yeah, I actually really think both Blair and Jeff gave really insightful answers, but I agree completely with Jeff that I don't want to trust my patients to I sort of want to make an idiot-proof hip here for, particularly for this question of stability. And so, just one other approach that I will take in addition to dual mobility is, and being very careful with cup positioning and provocative testing. I'm very direct with a lot of patients up front if I am worried about them for instability postoperatively. I have very little hesitation to talk to people about slight lengthening or going to high offset as well. I think both of those things, we always want to match offset to their native anatomy and leg length as well. But if you have that conversation up front, a couple millimeters of offset and a couple millimeters of leg length go a long way in terms of improving stability. And so, particularly in hip fracture patients, that's a group that I now am doing a lot of anterior approach hip replacement on. We have a fair number of these fairly active, 70 something year olds that come in with hip fractures. And I will tell them and their family up front, we're going to make the leg just a little bit longer. It's much safer for you. They come to you with an injury. So I think they're very understanding of that. But that's, one additional strategy that I'll use. And I think if you counsel them up front, it's incredibly useful. They're not very upset about it. They tolerate it quite well. But yeah, all the things that we talked about, I think we've paid an incredible amount of attention in the orthopedic community in the last 5 years to spinopelvic issues and the role of dual mobility there. Um, I think that's something we're still beginning to understand more and more, and we still have a ways to go there. But I think certainly it's one of those issues that if you see somebody that you're concerned about this, you start to go down the dual mobility route in your head, uh, in addition to the other things we talked about.
So, Chance, I actually want to stay with you on that topic for a moment because obviously hip spine mismatch is sort of a big, as you pointed out, something that we're thinking about. We've been thinking about significantly over the last 5 to 10 years, at least in hip surgery. So, how do you think about hip spine mismatch when planning an anterior approach, especially in patients that you think are presenting for a higher risk of instability? Is dual mobility just your option, or are there other things you're doing to plan for sort of the hip spine relationship?
Yeah, I think, I will not pretend to be an expert in this space. I think there's a few people who have really carved out a niche in the spine pelvic world that are doing really good work there, and I will defer to them, certainly. But my sort of antenna goes up, or my red flag goes up with a couple settings. One is obviously the one where you see a huge amount of spine hardware on your AP pelvis. So you see the destroyed hip, but then obviously staring you in the face is the screws that are extending down into the ilium. And those are ones I always worry about. I think those certainly you have to begin to go down this other sort of pathway. But the other ones that can be a little subtle are the ones that come in that don't have hardware in their back or in their pelvis. And they have an abnormal view on their, you get your traditional AP pelvis, and you see that it's either an inlet view or an outlet view, rather than being a typical AP. And it just kind of draws your attention to the fact that they might have something abnormal in the way they carry their pelvis. Because if you have a radiology tech that you trust that is shooting your films regularly, you get a weird view. That's certainly somebody I start to worry about a little more. And so, I think once your antenna is up for those, you can go down the pathway of whether or not it makes sense to get sitting and standing. Lateral views of the spine and the sacrum. I've found the concept. I forget who raised this, but the stuck standing or stuck sitting approach is pretty helpful as I'm thinking about how I'm going to approach these patients. But when I identify one of those patients, my other goal is I want to put their cup in a really good position. I want to make sure I put it in a spot that's functional for them, and then I still have dual mobility as the backup. But I try
Mhm.
and trial with standard liners. So I will typically try and get a 36 neutral trial liner in. And I want to have a hip that feels stable to me with a neutral standard liner in. But then I'll typically, when I do my final implant, go to a dual mobility and OR3O type construct.
Mm. And Jeff, how about you? Are you routinely changing your cup targets based on maybe spinopelvic considerations?
Yeah, I think this is a very, we're on the tip of the iceberg in this topic, and I think that you could do a whole podcast on that if you wanted, but we at UCSF actually were some of the first people to write on this, and I did my whole grand rounds when I came back as faculty on this whole topic, and I think the take home message is that they are higher risk, yes, but it's not really going to change much of what you're going to do in surgery. And I say that with the caveat that when I'm doing a hip replacement, I'm looking at their functional position of their pelvis. And to me, that's a standing AP film. So a standing AP film tells me all the information I need to know about their spine from a DA approach. Like Chance was saying, if you get an outlet view, they have a flat back, right? If you get a inlet view from a standing position, they have hyperlordosis. And so if you put that cup in the right position in that functional plane, and for me, that's about 20 degrees of anteversion. If I can make that functional plane reproduce in the OR and I can put the cup where I want in that position, that is how I address spinal pelvic issues. I do go back and I fall back on that OR3O, the dual mobility in cases where, it's a extreme, like they're an Anx Bondy patient or they got the quad rods and, all that stuff in there, then yeah, sure, I'll maximize my stability with the dual mobility. But I think that the cup position does not change for me based on the mobility of the spine or whatnot. It's where are they when they're standing.
Mm. So, Blair, this concept is complex enough for orthopedic surgeons. How do you explain it to patients in a way that maybe builds trust in what you're going to do during their hip replacement?
Yeah, I mean, I think a lot of it is just trying to explain to people that, the motions of transitioning from sitting to standing is a kind of a combination of the lower spine and your pelvis and your hip. And if you're fixed in like of those three places, if you're fixed in one or two of those places, you have to compensate through the final mobile areas. So if they have a lumbar spinal fusion, it's then all of your remaining motion to do your activity of daily living have to come from your pelvis and your hip joint. Or if you're again have, the hardware extending into the pelvis, if you have lost complete motion in your spine and your pelvis and you're only relying now on your hip joint, you have to have a lot more compensation in the hip to be able to accomplish that. So I think most people kind of understand that normally these three areas work together, but if you're knocking one or two of those areas out, then the remaining mobile area is doing a whole lot more in terms of its compensation in order to allow you to lead a normal life.
Mm.
And so I think that's kind of the easiest way to allow people to understand that. And I myself am a visual person, and I think a lot of patients are. So I have models in the office. I have like a pelvis, like a, just a sawbones pelvis. I have the, kind of hip replacement models. And I think sometimes it's very helpful to kind of show people that. And explaining that, on these x-rays, these are two-dimensional images of a three-dimensional problem, but then kind of going to the model and saying this is what we're actually talking about in terms of these activities of daily living. And again, it's hard enough again for surgeons to really get in the weeds. This is not an easy topic to understand, and the nomenclature can be confusing, and the measurements and everything else. So I'm just trying to, I think, address it to patients in terms of if these things are stiff, this last thing has to be flexible. And for it to be flexible, it needs to maybe move in places that we do not normally anticipate. Um, And then kind of again going back to the tricks or the solutions we have in the OR to address that is kind of that, is a nice segue into that conversation.
So,
I was just going to add, Dr. Schwab, sorry, I think Blair's answer is really good. And patients love to hear that you are thinking about that
mm,
before surgery. I think it really is a nice way for them to feel that you have some expertise, is that you kind of raise this issue and you show them that you're thinking through it. And if you can be visual about it, even better. But it really builds trust. And so if God forbid something does happen post-op, they know that you weren't caught by surprise on this. They know you thought through it ahead of time and addressed it with them ahead of time, and it seems to engender a lot more easy conversations about complications than if they happen as well.
this episode of the AHF podcast is brought to you by Smith and Nephew, a portfolio medical technology business focused on the repair, regeneration, and replacement of soft and hard tissue by using technology to take the limits off living. They deliver on this mission every day, making a difference to patients' lives through the excellence of their product portfolio and the invention and application of new technologies across their three global business units: orthopedics, sports medicine and ENT, and advanced wound management. The Smith & Nephew Cori surgical system offers proprietary tools and software across the full suite of procedure solutions to deliver a platform that is flexible and scalable across knee and hip joint arthroplasty indications. Choreograph pre-op planning and modeling services combined with the RI Hip Solutions and the recently launched Catalyst Stem primary hip system offers a complete solution for primary total hip arthroplasty. To learn more about Smith & Nephew Revision Hip Solutions, visit smithandnephew.com. Are any of you using tools like, for instance, like a choreograph that help you model sort of spinopelvic mechanics that might affect your cup targets? Are any of you doing that in front of your patients? And does any of that sort of meaningfully change how you plan for instability risk?
I don't, but I I will say there are some cases where I think a tool like that was easy to execute in the OR and easy to obtain ahead of time would have a lot of value. I mean, when we get these patients that come in that have been multiply operated on elsewhere and they're, still having stability issues, if you have the ability to deliver a fairly simple tool that you would be able to obtain ahead of time and you'd be able to model for yourself and then execute in surgery to match exactly what your plan is, I do think that's a valuable proposition, at this point, because we can plan a lot, but if you can't match it to an execution in the operating room, that takes away a lot of the power for you. So, but I think the key is that it's got to be something relatively simple and easy to obtain. And so, something like Choreograph, which is CT based and allows you to get some fairly complex planning ahead of time, I think does have value compared to some of the other options that are out there.
Yeah, I think to your point there, Chance, I think the other value of this is it gives you some confidence that you've optimized things, right? Like if you've put the components in a position that's optimized for impingement, implant impingement, you at least can check off that box that you've done everything possible to make the component position aspect of the surgery perfect, right? You still have to worry about soft tissue, you still have to worry about abductors, you still have to worry about some of these other things, but at least gives you that peace of mind that, hey, I've done everything I want or could do from a component
Yeah, I'd
position standpoint.
also add that I feel like I don't use this now, but I think in terms of the world of as we develop, robotics and the kind of intraoperative guidance and planning tools, like I have a lot of optimism for things like this. I'd say as someone else, like Chance, I do an off-table direct anterior, so I feel like I get really good functional testing intraoperatively. Like I do, I'm moving that hip through all kinds of crazy ranges of motion, and so that tends to give me. Um, like, relatively good confidence, I think more so than just I think sometimes I felt in training of doing those tests on a table where I feel like you don't necessarily get as good posterior testing or, you can't really get a figure of 4. But even I'm thinking of one patient in particular, even with all this tests being perfect in the hour, this patient who had an extensive lumbopelvic spinal fusion did dislocate, and it was something I ultimately needed to revise. So, kind of thinking of patients with those high complexity and again, patients where you really want to be sure, like to Jeff's point, you can check off that box that I did everything I could to optimize my position the first go around. I think that is eventually going to become a very powerful tool that maybe you're not using with every patient, but with these higher risk patients, again, I think I'm very optimistic about how I could integrate that going forward.
So, Blair, right now, just to kind of stay on that, those higher risk patients, patients with neuromuscular conditions or prior instability, or maybe, we talked about compliance concerns. How do those factor right now into your initial surgical plan rather than, something you might deal with after the fact?
Yeah, for me, those patients in that category are automatically getting like an Oreo cup, an MDM cup, and a high offset stem, like, automatically, basically.
Mm.
I'm doing everything I can, in addition, obviously, to appropriate cup positioning. I think that's a given. We can all assume that. But in terms of what am I doing in addition to that, those 2 things that's my default. I'm MDM, high offset stem.
Are the rest of you sort of picking kind of specific, we'll say, pro stability constructs? Or maybe, Chance, I'll ask you, at what point do these sort of risks push you towards maybe a different construct strategy than what you might use in a normal primary?
Yeah, I think, as I mentioned before, there's certain patients that you plan to have extra stuff on hand, but I like to template my cases ahead of time as well. And so when I'm looking at on my template, and if I'm seeing anything out of the ordinary, then that's a text to the rep to say, hey, let's make sure we have OR30 available on, for this case. And then I think I've also, as I've gotten a little more experience, it's funny, I go sort of back and forth on high offset stems. For a while, I hated high offset stems. I tried to avoid them because I don't know, I felt like I had patients coming in complaining of throat bursitis a lot, and so I kind of stay away from them. Now I've kind of gone back to them because I do think, if you take a modern stem like Catalyst stem, for instance, which has very graduated neck options. Um, there's a lot more nuance now that you can achieve in offset and leg length, where some of the older stems that I used to use, you would jump, the high offset would be a dramatic increase in offset. I mean, sometimes on the order of, 10 to 12 millimeters.
Mm.
And that just was too much for some folks. But I think now with these graduated necks, we have a little more ability to fine tune that. And so I will have those. I have a shorter uh, sort of threshold for jumping to a slightly higher offset because it doesn't seem quite as provocative to the abductors.
I think to that same point you were talking earlier about, telling the rep what to have. I think with the R3 and the OR30, like the transition to the inertia needed to switch to a dual mobility is so low, right? Like as you were saying, you can trial with a 36 liner, like everything, and then you get the bonus of the extra head size by easily switching to a dual mobility. The liner just goes in so easy, like it sits flush, it's easy to tell. You don't have to worry about cobalt chrome, which, by the way, every cobalt chrome junction in the history of orthopedics doesn't work, right? Or has had issues. So don't put that in. Why are we still putting those in? Uh, but it just makes that decision a lot easier. The one place where I will kind of still take pause is I have a lot of my practice is a lot of very young patients. I do still, I will need a reason to put a dual mobility in someone under the age of kind of 40, just because it
Very
is a
young.
different poly. Was that Well, I get a lot of teenagers, 20-year-olds. We get a lot of young patients. But the poly is different on a dual mobility, so you need to be aware of that. It's not a fully congruent poly for any of these dual mobilities, so it's a little bit of a different wear mechanism. So those are the one place where, until we start seeing kind of 20-year data on that, I'm going to be a little bit more cautious. But um, older patients, throw it in without any hesitation.
Jeff, I actually want to ask you a little bit about that young patient population. And honestly, I'm going to go off script here a little bit, but you raised an interesting question. Um, The is your patient population that young because of things like AVN or sickle cell disease, or what's the genesis of that young a patient population?
Yeah, I mean, so I'm at a tertiary care center, so we have quite a range of reasons, but it's a mixed bag. We have a big cancer center, so a lot of it is AVN after chemotherapy or stem cell transplants or things of that nature. Also, a lot of dysplasia patients, right? So we get a lot of patients with bad dysplasia. Um, or I just saw a 14-year-old yesterday with a skiffy that failed. We had a 16-year-old who had a car accident with a posterior wall fracture dislocation that went on to AVN. So, some of it is just, we all get these little niches of patients that come to us, but it's also just being in a tertiary care center.
Yeah. Um, so both Chance and Blair kind of mentioned their sort of off-table setup, and even mentioned a little bit about what they're doing from an intraoperative stability check. Jeff, I want to ask you: are there sort of non-negotiable intraoperative stability checks that you're doing in your cases before you feel comfortable closing?
Yeah. So I think number one, my number one stability check is actually just reproducing anatomy. So if I'm happy with leg length, offset, and component position, that's my number one check, so to speak. In terms of positional checks, I had one surgeon one time tell me that if you've done something, for 200-300 straight cases and never changed anything, you probably can think about if you need to keep doing it or not. And so, for my first probably 5 years of practice, 1,000 plus hips, many more, I was doing stability testing on the HANA table. And for me, that would be externally rotating to 90 degrees and then dropping the leg halfway to the ground. If I had no subluxation in that position, I was happy with stability. Um, 4 or 5 straight years, I never changed a patient. And so I have actually stopped doing that if I'm happy with my component position. I have not been burned from a DA approach yet with stability. The thing that makes me more cautious, so to speak, is and actually the most afraid of a dislocation is soft tissue issues with patients. So if you're doing a reduction, if they're under a normal anesthetic, for me that's a spinal. If you're doing a reduction and it's the same person doing the reduction for you on the HANA table, it usually does it, and it just kind of flies an inch away from the socket. That makes me more nervous than stability testing. And so in those situations, it may be a patient where I would put in dual mobility, or it may be a patient who, for me, I might give precautions for a few weeks. So going back to Blair's point about, these early few weeks is the most high risk period. I may just after surgery counsel that patient like, hey, I'm very happy with how everything went. The stability checks were very good, but your soft tissues are a little lax or whatnot. I just want to be extra cautious for you. Let's just do these precautions for a few weeks. And most patients are very open to that and they kind of get it. And it just sets in their mind like, hey, I got to be a little bit careful and slow down for these first few weeks. Has not been an issue long term after that. But those are more the things that worry me.
Blair, are there checks that you routinely do that you think maybe get rushed or skipped maybe by other surgeons?
Well, I will say I think the one with the DA approach, I think we all kind of take for granted that like, oh, I'm not that worried about posterior instability, like it's kind of in the back of one's mind. So, when you do an off-table DA, like you can check that. Like I flex the hip up to 90 and sometimes past 90 and internally, externally rotate. And I think that's probably one that's easy to kind of skip or rush through. Just because again, you kind of we're like, oh, well, I'm doing this because I can do it, but like, what is the likelihood of this actually dislocating posteriorly? And
Mhm.
every once in a while, when I'm doing that and I have my finger kind of on the articulation, I'll feel like a little osteophyte I missed or something that could be a source of impingement down the road. And I will kind of like to just point, I'll go back and change it. So it's like for me, it's something I'm still very cognizant of, but I think it'd be an easy thing to kind of rush through. But I'm very reliant on my intraoperative stability checks because I don't use fluoro, like I'm using all anatomy, component positioning, and I'm relying on my stability checks. So that's kind of just, again, it's a different, like you, depending on what you're using, you're perhaps weighing that information differently. So for me, it's like kind of the figure of four because everyone's trying to put their shoes and socks on by putting their foot up on their other leg. And then again, that posterior stability test, in addition to just kind of leg length and whatnot. But I think the posterior one's easy to skip because we kind of take that for granted.
Mhm. Go ahead.
Can I just make a comment? As an on-table person, there's like early in practice, a couple of times I would take the boot out and check posterior
Mhm.
if I was really worried. And to be honest, I didn't know what to do with it. Like I didn't know what position I was gonna be okay. I didn't know how far it was supposed to go. Like sometimes it would sublux and go right into the capsule. So for me, I was like, I don't know what I'm doing here. I don't know what I'm gonna change. Like, what am I going towards? So for the on table people, don't worry if you're not checking posterior. I think more important is like make sure you're not violating the posterior capsule. Make sure you're doing appropriate
Yeah.
releases. That's
And
probably
you're
more.
getting information as an on-table person that I'm not getting, right? Like, you get more reassurance that you can see what your offset is, and you can, so you're getting that information elsewhere, right? So, I kind of do it based on my templating and what feels appropriate then when I'm, testing these patients functionally. So, it's just getting that information from a different place.
Chance, is there, I'll say, maybe an intraoperative red flag that you see that tells you something isn't right, even if maybe everything else would indicate that the hip feels stable?
Yeah, I think there's a couple, and they almost make my blood pressure rise just sort of thinking about them because they can be really frustrating. One is when I work with the same PA every day, and so all my hips, I know it's him pulling on the leg, and so there are times where we go to do the reduction, and like Jeff mentioned, it's way too easy, and I go, "Oh, that was really odd. That took 0." I can tell that he had to pull with minimal effort and the cup just or the ball just drops right in, even though all the positioning looks perfect. That to me is like I start second guessing and I wanna go back and be really careful about make sure our imaging was accurate and check the anatomy again. And then the second one, which I mentioned earlier, is my bar stool test, which is, and that actually, the other one I like for that is I will, keep the leg in sort of a neutral, flexion extension, but hyper adduct the operative side and
Mm.
externally rotate. So sort of bring the heel over to the other heel and then, try and drive the foot into external rotation and just see if we get any posterior impingement. That's one that I think can be a subtle indicator of some over anaversion of your cup or over combined anaversion, and so, that's another one that I look at pretty carefully. I think that's a really important test from the front, at least in my hands, so, but yeah, that soft tissue, question becomes a big one when, if you're just not quite, things just don't feel quite right based on your reduction tension, even though everything else looks good. I think you do have to think a little bit about soft tissue and patient anatomy in that case in terms of just their neuromuscular function.
Mm.
Mm.
So we've had a nice, actually, sort of little side discussion here about, the sort of information that you get in an on-table scenario versus an off-table scenario. And just thinking about that from the different perspectives that you guys have, are any of you using something like RI hip navigation to help you hit your targets? Is anybody using any navigation above and beyond their anatomic guidelines or their fluoroscopic input?
I'm not, but hearing Blair talk about not using fluoro, is very appealing to me because, I will say fluoro is easy feels easy to get. We have good fluoro at the ready in the hospital, but, recently, I operated in an ASC and, for about half my cases, and recently our radiology tech went out. She had a hip replacement. So, we've been without a RADS tech, and so I've had the nurse push in the machine, and then I'm either hitting a foot pedal or, and the variability and quality of that imaging is, high. So it would be very appealing to not have to be beholden to X-ray, and so, as I said earlier, I think if there were an easier or an easy, excuse me, solution, to to use some kind of navigated scenario that would be easy to implement in the OR, not very costly, especially if we're in an ASC setting, and then would give me reliable information. I think that would be a pretty appealing thing for me, just to get away from being beholden to fluoro at all.
Mhm.
I think what you're gonna find in the future is right now we're like right on the brink of we can kind of navigate things, but we can't necessarily execute the preparation and the navigation together. And so I think the next version of this is going to be the one that starts to gain more widespread adoption for the reasons Chance was just saying. Like, we don't love using fluoro, we don't love wearing lead. It's another person that has to be in the OR. You got to wait for them to show up. So I think once we can plan a socket, prepare a socket, and then put the socket in all through the same ecosystem, which is on the verge, coming soon to an R near you. I think that will be the one that's going to gain widespread adoption for hips.
Hmm. So, talking a little bit more about actual components and the components you might use for instability, Blair, I want to go to you because both sort of Jeff and Chance kind of mentioned this, being able to sort of trial with standard components, but then switching to like an
Right.
OR30 right at the point of actual implant placement. When you are dealing with a patient with an elevated instability risk, how do you think about escalating your construct without necessarily jumping immediately to the most constrained option? And we really haven't talked about constraint per se, but there's variability in how one can define that, I think.
Yeah, for sure. I mean, as I mentioned, there are patients I'm just planning on using an MDM. So if I'm planning on using like an R30, I trial with an R30. I like to, it's kind of just like a practice how you play thing for me.
Mm,
But for patients who maybe aren't quite that extreme, like, or maybe they're not even anticipating having a stability problem. I do try to optimize my head size. So if I have the option to use a 40, if I'm putting in a big enough cup to use a 40 head, I'm going to a 40 head. If the 36 is my maximum, I'm doing a 36. So I do tend to trial with the largest head size available, like even just for like a normal head liner, with a neutral liner. And then I think I alluded to earlier, there are some patients who I sometimes worry about an offset problem based on my templating. Some patients have a lot of native offset, or I know maybe they have some dysplasia, so I'm really medializing their cup, and then I'm kind of creating an offset problem. And for those patients, I don't typically trial my liners, but for those patients based on my template that I'm like, ooh, am I going to have trouble recreating that patient's offset? I will sometimes trial with a neutral liner first, make sure that I'm happy before putting in that neutral so that I have the option to trial with a lateralized liner if needed. Again, going back to if I'm concerned specifically about that offset problem.
mm,
And then, of course, there are also, I mean, there are kind of just the lateralized liners, but there are also lateralized liners with an elevated lip, which is an option that exists. That's something I'd like to have. I like to know it's around, but I very rarely use. I would be more likely to go to an R30 before doing something like that. But that's another thing to have available to yourself.
mm.
I was actually just going to ask Jeff and Blair that on that very topic, Blair. Do you guys ever use a lipped or face change liner from the front? I don't think I ever have, but I encounter it now and then when I'm revising. Other folks have come from
Mhm.
elsewhere, and I'm just curious what if you guys think there's a role for those. The lateralized makes total sense to me if you're trying to get pure offset, but I'm just curious about the lip or the face change if either of you guys do that.
Never in a primary
I can
setting.
think of,
Oh, sorry.
yeah, I agree. It's like I can think of maybe I can think of two patients, in 5 years, and both kind of like conversion scenarios, or like some kind of revision scenario that I use that in. Cause then you worry about like, well, what if I'm putting that elevated lip in the wrong place and I impinge and I create a problem for myself elsewhere? That's the part that I'm always worried about with that. Yeah.
Yeah, for
Mm.
me, it's never a primary option. There's a well fixed cup that I'm trying to salvage, and it's a revision solution. Yep.
Mhm.
So, Jeff, you also mentioned, your number one sort of stability test, right, is anatomic reconstruction. And so, talk to me a little bit about how you see offset and leg length optimization in the stability sort of workflow for your patients before you think about changing or escalating maybe your constructs.
Yeah, I think that the human body wants to go back where you found it, right? Like that's where the muscles are designed to be. That's where they're used to their kind of range of motion to impingement. And you got to remember the head neck ratio of a native hip is horrible, right? So like they're used to impinging sooner maybe necessarily than your construct's going to be. So I think if you can reproduce those things and you haven't destroyed the soft tissues, you're generally going to be okay from a DA approach. Now, that said, I think that you have to be able to, number one, check that. So with fluoros, the way I do it, or, a lot of templating or navigation or whatever it is. But number two, I think there are system-based issues that make this easier to achieve, right? So Chance already mentioned this, like Catalyst Stem has a great kind of graduated thing. Every size is a 0.5 millimeter more of length and 1 millimeter more of offset. It's really easy to remember that, right? If you go from the standard to the high, it's a straight lateralization. You're just getting straight offset. So it makes that kind of fine tuning in the OR very easily achieved. And the other thing is, when you have oxinium heads available to you, there's more options in terms of your minus and plus, as opposed to some of the ceramic offerings. So you have this kind of fine tunability that doesn't exist with other systems. And the other thing is, if you go to a DM and you have an OR30 in there, it's a smaller head. You get more of these 28 and 22 head options with oxinium than you would in the ceramic options. And you already heard what I think about cobalt chrome. So I think that ability to get the target right is very nice with this system, or with the Smith & Nephew system. In terms of like, when will I add length or offset? Really, I try to avoid it. You got to remember, the people that are unstable, like these old frail ladies with like no muscle tone, they're the ones that hate high offset the most, right? Like, they're the ones that are always complaining of bursitis. So I'm trying to avoid that if I can.
The one thing that I haven't heard anybody sort of really mention, and I'd be interested in sort of hearing the group's thoughts on this, is true constrained liners. Is anybody using those in any scenarios at this point, or have dual mobility options like the OR30 really made that, if not obsolete, extremely rare?
I mean, I guess I will say that is a last resort for me. I I find all constrained liners annoying to put in. They are obviously something where you kind of have this theoretical, like you're putting more kind of strain through your system, right? So it can accelerate the kind of, or I guess shorten the lifespan theoretically of your cup. So certainly I mean, you really want to put it in if there's a well-fixed cup. So you're almost by default putting it in a revision scenario. There's some literature that exists that say you could use it primarily as long as you have like 5 screws, or, a certain number of screws for good fixation, but that would give me pause. And so for me, because there are, I think, so many other good options in terms of augmenting your stability with the different liner options and the dual mobility liners, and hopefully you still have some ability to add leg length, assuming that scenario had not been exhausted during the primary. I constrained to me is very much a end of the road situation. And ultimately, constrained liners are a solution typically for abductor insufficiency, and hopefully that is something we see less from the front, and certainly as DA is more popularized, that's perhaps less of a problem. But you really just I think it's important to still be critical of cup positioning. You don't want to put a constrained liner into a malpositioned cup. That's just the wrong thing to do. So I think it's very much a last resort situation.
I think for me, the only primary situation where a constraint is an option is tumors, and so those are a totally different ballgame, right? If you're taking out the proximal femur and their abductor, that may be a situation. Even in those, I've gotten really bold with OR30 and dual mobility constructs. If you have no abductor, the way it dislocates is usually sliding out the side and abducting, right? So take some abduction out of your cup, like really keep that cup almost flat, covering the ball. And with these, you put in a 50 ball with a dual mobility construct, those will be surprisingly stable, even with no proximal femur, no abductor muscle in some of these tumor situations. And so I'm going to let that fail before I go to a constraint option. Similar to those lip liners, constraint is a revision tool, not a primary for me.
Lance, how about you?
Yeah, I agree completely with the previous comments. Saved for a last resort. I think of it in case, Jeff mentioned big, massive resections. Huge infection is another one where
Mm,
you've already been in the hip and had to take away a lot of bone or tissue because of infection, and you're concerned when you come back. But typically, those are, again, I do that from a posterior approach. If I've done a case like that, and so I think there's already a little increased instability risk, but I would rather see a dual mobility fail before I would think of going to a constrained. I think you're being more friendly to the hip by staying away from constrained as long as possible.
mm.
Can I just make a comment that I was looking at the HAR yesterday in preparation for this, and a crazy statistic to me was that in revision hips, 25% of liner choices are constrained. Like that is insane to me that revision hip
Oh.
bearing option, 25% in the US were picking constrained. So I
That's
That
haven't seen
Jeff,
that
aggressive.
many, but
that was
so
current to like this year or
that was
like a
2022 data or whatever is like the 2024 report that I
wow.
was looking at. So a little bit older one,
Wow.
but yeah, 2020.
Yeah.
It was crazy. Yeah.
Yeah, that's
That's
wild.
surprising. I feel like we need to have
Yeah.
those surgeons on the show to explain what they're doing, huh?
Yeah, exactly.
We're getting close, and I appreciate all the time that you guys have spent with us. And I just have a couple questions left for each of you. And Blair, I want to start with you. So we've talked a lot today about instability, and we've talked about it from a number of different perspectives. If you had to describe it sort of conceptually, your sort of end to end, beginning to end, maybe instability prevention algorithm. Now, obviously, everything's specific to each patient, but from kind of clinic visit where you're deciding to go ahead with a total hip to a final construct, let's say in a primary, broad strokes, what does that look like in practice?
Yeah, I mean, I think, kinda first interaction, it's mostly like, what am I worried about with this patient? Is this kind of like my standard risk patient, or are they a higher risk patient? Not just for the conversation with them, but more for me, again, to kind of like Chance and Jeff's point of what do I tell my rep that I want, right? What do I wanna have available? What's in my brain? And then the next step for me is templating. And templating is very important to me because I'm not using intraoperative imaging. So based on that template, I'm already deciding like, am I worried about my offset? Do I need those lateralized liners? Am I leaning towards a high offset? Am I leaning towards a standard offset? And what's going to be appropriate there? And then intraoperatively, again, kind of, putting the parts in the right spot, right? Which is we all strive to do from the get go. And then the intraoperative assessments and some of the even the choices between those two things. Like if I have a very small cup size and I would only get a 32 head, that might be a situation where I would use like an OR30 to get a bigger head size, even if someone's not necessarily a stability risk. So some of those like finer tuning those decisions and then I think again, kind of is the point that Jeff brought up is that particularly with catalyst stem, when you have these gradual increases in terms of offset and leg length with each stem size, that might be something where as I'm trialing, if I'm getting higher up in my like, neck length and I'm at a +8 and thinking about going to a +12, at that point, I'm saying to myself, look, I'm going to upsize my stem, maybe sit it up a little bit, gain some length and offset from the stem, and then reserve myself some neck lengths as I'm going up if I'm trying to reestablish those things. So, yeah, I think it's what am I worried about walking into the room? What is my template telling me to expect? And then how do I pivot intraoperatively? Those are kind of my biggest things. And then thinking about heaven forbid I have to come back here, what would my next surgery look like and what options have I left for myself?
Hmm. And so, Jeff, when you hear algorithms like that, which I think is a very comprehensive one, and lots of surgeons have different algorithms for their instability risk, where do you see most of these algorithms breaking down in practice?
Well, I think number one, you have to have an algorithm, right? So you have to have a routine that you're doing every time that you can address. We're creatures of habit, right? We do two surgeries basically. Like you need to have a routine. And I think where they break down is when we fall out of that routine. So you crack a femur, or you have trouble getting the cup to fit, or you're having trouble with exposure, or something is off from your normal workflow, that's where then instability kind of creeps into the equation. So I think just being vigilant and kind of always going back to your same checks, your same routine, same cup positioning, like have a workflow and stick to it. I think that's probably the best way to avoid it in the first place. And to Blair's point, if do a lot of this in the pre-op space, right? If you know they have a risk factor, have the OR3 available, like already have that planned out, ready to go. Like don't then get distracted by, it's a dysplasia case and you're struggling with getting the cup right where you want, and then not think about it at the end. Like have that already planned before you start the surgery.
Mhm. Chance, I want to hear from your perspective because we have a lot of young surgeons who listen to this who are kind of working through what their algorithm is going to be, what their surgical approach is like. If you were to identify a single decision point regarding instability that has sort of the biggest downstream impact, meaning if you've got surgeons who need to learn, we talked about a lot of different issues today that affect instability. But what's the number one decision point that has the biggest downstream impact for patient stability after an anterior approach?
I think there's probably a lot of viable answers to that question, Joe, depending on what your workflow is. But I think a simple one would be, what maybe starting, very relevant to what we're talking about today is what family of implant am I going to be living in for the majority of my cases? Because um, I think uh, breeding familiarity with your implant system through a lot of the nuance of where surgery varies, it has a lot of power for you because even though, like Jeff said, we're doing the same one of a couple different operations over and over and over again, there's incredible nuance from patient to patient. Your exposure can be a little different based on patient muscle tension or muscle bulk or what their blood pressure was doing that day or how much um, little change in the position on the table or who you're working with, et cetera. And so having an implant system that you use all the time and that you know how to get the best results out of, I think is really important. And when things are different. So if you're doing the same thing all the time and using the same implants all the time, you appreciate these little differences where you may say to yourself, that was a little different than usual. Something's off here. I have to check that. But then also understanding where, if you have an implant system like R3 that can run from a very standard neutral offset liner to a lateralized liner to a face change to a dual mobility. Having an implant system like that gives you incredible versatility, I think is really valuable. And then same thing on the stem side. Um, that positions you for success because you're not going to find yourself stuck going, oh, I wish I had the ability to do X, Y, or Z, and dang it, I can't do that with this implant. And so I think that's probably a big, simple one when you're starting practice is to say, I'm going to get really familiar with this family of implant. I'm going to use it all the time, and that way I know what I'm dealing with. I think would be a good place to start.
So you've all been super generous with your time. I really appreciate it. I have kind of one closing question for each of you, sort of an opportunity to maybe provide a little philosophy or a little bit of parting wisdom to our listeners. And Chance, I'm going to start with you. When you look back at some of the instability cases you've managed, what's one mindset shift that changed how you do anterior approach hips?
I guess what I'll say for one big thing that I probably changed at some point early on is, um, and this came up earlier. I don't want to blame the patient for for anything. A mentor of mine early on said, he said, when you're taking care of patients and somebody comes back with an infection, you feel terrible. You wonder what could I have done differently, man. I'm really bummed out. But when they come back with a dislocation, you get, you get irritated at them. And I always thought that was an interesting remark. And I've certainly felt that. But so a mindset shift that I've tried to adopt, and as we mentioned earlier, is I want to really make an idiot-proof hip. because I don't want to find myself getting mad at my patient because they did something that I wish they hadn't done. I kind of want to set them up that, I live in the world of Florida man here. So we have some poor decision making that happens on a regular basis. So I'm going to assume that. And I want to leave the OR with a hip that I trust that even if they do something pretty stupid, they're not going to get themselves into trouble. And I think that's helped keep me out of trouble for the most part, especially as I've, in the last few years, as I've gotten more experience.
Blair, if you could help one surgeon avoid maybe learning the hard way when it comes to instability, what's the one thing you'd tell them to take seriously or to focus on from the start?
Yeah. Um, I mean, again, it's hard because there's like I feel like there's a rush of things that come to mind, but I think this has been brought up to some extent, but I think as with all surgery, respecting the soft tissues is just so important. Like we're orthopods, right? We're very bone centric people. But in DA hips, I think the management of the soft tissues does make a big play a big role. And specifically for me, I'm thinking of the femur, in terms of because sometimes in, bigger patients, maybe muscular males, sometimes it's really hard to elevate that femur. And for me, I know in the moment, I'm like, well, I want to see it better. I'm worried about breaking the femur. I want to see it better. And I really want to be able to elevate, especially for off table surgeons. That's not always, that's can actually be a very challenging part of your surgery. And so, I think just being very cognizant of that and balancing that, because if you release too much of those kind of capsular structures and you get into the, external rotators and the abductors and things like that, you can create instability that would not have otherwise been there. So I think sometimes it's just like taking a breath, only um, doing the releases that you really need to do
Mm.
to see what you need to see, as opposed to giving yourself like the most amazing visualization possible at the expense of these kind of protective soft tissue structures. I think that's something where initially I was just so focused on getting the best view possible of the bone. So, because I was so worried about fracturing, but maybe doing almost like more than I needed to do to accomplish that safely. And as I've gotten further along in my practice, I feel more comfortable with starting with more minimal releases.
Jeff, with you kind of mentioned coming soon, things like better planning tools and navigation and our implant options, certainly the ones that are available now, but the ones that are going to be available in the near future too. What gives you confidence about where instability management is headed? And what do you think is out there now or coming soon that sort of deserves some real respect?
Yeah, I mentioned this a little bit at the very beginning, but I do think that instability can be something that we kind of look at historically almost like polywear, right? Like technology was the way that we solve lysis and we solve polywear, such that now we're kind of spoiled. Like that's not even a thing anymore. I think instability can go to that same place where, with the right technology that can tell you where to get the cup, tell you where to position components, achieve that target, um, proper training, right? Like DA is now widespread in the US. People are coming up, learning how to do it appropriately with good soft tissue management. I do think this can become one of those rare to never events. So I am very optimistic that this will be one of those things that we're telling trainees about, like, hey, remember when we used to have to reduce hips, right? That would be really cool, right? That patients don't have to go to the ED and have their hips reduced. So I think that this is one of those places where it's a nice combination of implant tech, surgeon ability, and skill coming together, and hopefully eliminating this problem.
Well, I've really appreciated this conversation, and I want to thank you all for joining me today on the AHF podcast. Thank you for joining me for this episode of the AHF podcast. And thank you to our sponsor, Smith & Nephew. As always, please take a moment to like and subscribe so we can keep the lights on and keep sharing great content and conversations just like this. Please also drop any topic ideas or feedback in the comments below. You can find the AHF podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube /@Anterior Hip Foundation, all one word. Episodes of the AHF podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips happy and healthy.